Thank you, Amélie, for this kind invitation. Good afternoon. I hope everybody goes on well. I have not the first slide. Never mind. Huh? Currently, we know that there are more and more arguments that long COVID is only an extension of a viral disease, but no treatment addressing its underlying physiopathology is yet available, such as antiviral and or immunomodulatory drugs. However, also we have to be humble. We have few therapeutic options. A symptomatic approach is necessary and useful. So I am happy to suggest you the following plan. First, diagnostic stage, current available approaches, then the research therapeutic option, and to discuss with you the remaining challenges. The first stage is to identify specific diagnoses that can be treated by a detail-oriented and empathetic listing and to opt for complementary assessment. Once this stage has been obtained, you can have a specific organ-based lesion to treat, for example, hyperventilation symptoms, POTS, cutaneous urticaria, digestive syndrome, irritable bowel syndrome, etc. The second stage, as it is recommended in France, and you will tell me if it's different in other countries, it is a current strategy that is currently based on 4 pillars. The first pillar is the symptomatic treatments. The second one is the information and self-management by the patient themselves. The third pillar, very interesting, is rehabilitation. And the fourth one is the management of anxiety and disorder that are not always present, but if present, it's important to take that in count. Concerning the symptomatic treatment, they need to be individualized before finding a treatment tailored to each patient. So it takes often 3 or 4 consultations to obtain something. Regarding pain, we can use analgesic, anti-inflammatory drugs, or anticonvulsant in neuropathy. It's better to avoid high-dose corticosteroid. Also, low dose may be useful in case of some symptoms, for example, arthritis, myositis. For POTS, who is really frequent, beta blocker or ivabradine in case of hypotension can be useful. And in this context, there is a trial with ivabradine, 5 milligram BID, showing really an effect on the Hertz rate. So it's one of the first trials that was published. For bronchial hyperreactivity, that is also a frequent symptom, you can use bronchodilatator. Our colleague pneumologists often use high-dose prednisone. I'm not sure it is the best, but it is used. Always in this field of symptomatic treatment, a lot of our patients have digestive symptoms. So usual treatment like anti-ulcer may be used, but antihistamine, anti-H2 histamine is really useful in case of irritable bowel symptoms. Don't overlook also the possibility that some patients have gastroparesis, and in this case, we can use specific treatment, like in patients from ICU, low-dose erythromycins. The use of probiotic or butyrate supplementation can be also useful. A part of our patient, not all, it's really not a treatment who has to be given to all patients at the same time because we have different profile, but some of our patients, about 10-20%, have symptoms suggestive of mast cell activation. It's often a combination of symptoms, cutaneous, digestive, muscular, and in this case, antihistamine H1 and H2 combination can be useful. A poor diet, with histamine poor diet, and also sodium chromoglycate before meals. And in case you have to use very big dose or you have severe symptom, an allergologic advice is necessary. Antihistamine is a field where we have already pilot studies. Here, there is a pilot study of 20 cases of patients who receive either no treatment, either a combination of anti-H1, loratadine, or fexofenadine, and famotidine. And in the second trial, 14 patients received anti-H1 and anti-H2 versus 13 control. And you can see that at baseline, the patient did not differ for those symptoms: fatigue, brain fog, increased heart rate, and abdominal pain. But after 20 days of this treatment, there was a decrease not only in fatigue, but also in brain fog, increased heart rate, and abdominal pain. So, of course, if it doesn't work, we have to stop those drugs after 20 days or 1 month. But sometimes it's really useful. And a randomized trial is underway. You can find all the trials that are underway on the website clinicaltrial.gov. Concerning neurovegetative symptoms, it's much more difficult, as it is in the rest of neurology in general. You can first recommend to your patient non-pharmacological measures that are listed on the right of the slides, replace the treatment exacerbating hypotension, for example, beta blocker, tricyclic antidepressant, and seek for specialized advice in case of severe symptoms. Sometimes some patients need to get milodrine or fludrocortisone, but it's quite rare. So I will not list all the symptoms because, as you know, there is a long list of symptoms, but it is the same pragmatic attitude for sleep disorder, cutaneous symptoms, etc. So that was the first pillar. The second pillar is training the patient to self-management. A lot of patients, they overestimate their functional capacities and they are unaware of the situation responsible for symptom exacerbation. So such worsening may lead to a malaise that's called post-exertional malaise. So it's important to train them on energy conservation technique, and the global word is pacing, and my colleague Fanny Brunet will detail this approach. She will also detail the third pillar, that is rehabilitation. There is a lot of rehabilitation possible in different domains. We don't know exactly why it works. Probably it educates some region of the brain that are not armed to compensate the regions that are armed. The fourth pillar is the management of anxiety and depressive disorder. So also not present in all patients. The screening of those manifestations is important. Some patients may have, for example, post-traumatic stress because they have been in ICU for 1 month. Some also have suicidal idea. So it's really important to discuss with the patient directly of these aspects. And the classical treatment are really not contraindicated. For example, on anxiolytics, antidepressive drugs, and mainly of the series of selective serotonin or noradrenaline reuptake inhibitors. And we know that serum serotonin are low in COVID. So those drugs probably increase the level of serotonin, and it's known also that those drugs have other properties, immunomodulatory properties. And in mice, for example, it has been shown that fluoxetine was able to reverse some neurocognitive function. It's for Guillermo. Okay, so probably also in man, those drugs can also improve the cognitive function. So let's move now to the future. Many clinical trials are underway for the treatment of long COVID, but there is few causal intervention. So I took from the website those that could be interesting and class them into 4 classes: those with antiviral potential effect, those with immunomodulatory effect, those concerning anticoagulant approach or oxygenation, and the last part, rehabilitation approach, and also Fanny will deal with that. First, be aware that all those studies published so far are really small study, usually pilot study, sometimes randomized or not. They lack power. The relative effectiveness is quite low. The rationale is not always clear, but it's like that in medicine when you test. And there is no follow-up. It is a main drawback. So you have an effect, but you don't know when you stop what will be the evolution of the patient after. Anyway, what is available concerning antiviral approach? After having observed some case of improvement with Paxlovid, also there is relapse. There are several randomized trials that are currently testing Paxlovid, at least two. One, the Pax Long COVID trial that has enrolled 100 patients in two arms, one arm with 15 days Paxlovid and 15 days ritonavir in the other arm, and a recover trial with 900 patients, so much more ambitious, with three arms, one arm receiving 20 days of Paxlovid, one arm 15 days of Paxlovid, so 5 days is not sufficient, and one arm with ritonavir. So both trials are underway, but I think we will have the results at the beginning of next year. And you can see that the main endpoint is for the moment a clinical endpoint. I think there will be sub-study within those trials for virological endpoint. Another trial, very interesting, it is a temelimab long COVID trial. Temelimab is a monoclonal antibody directed against a protein, the name is HERV-W, involved in microglial activation. This protein is a retroviral protein, endogenous human retroviral protein with abnormal expression, can be triggered by SARS-CoV-2. It's present in brain of patients with multiple sclerosis and sometimes in patients with SARS-CoV-2. And when it is present, it aggravates the phenotype of microglial cells in aggressive phenotypes and gives a lesion. So the patients that are included in this trial are patients with long COVID, with neurocognitive disorder, and who are positive for HER2. There is a phase of screening. They receive temelimab, IV, several infusions over 6 months, or placebo for 6 months. The main endpoint is also a clinical global health endpoint. So I know that there is 2 trials that are nearly have finished the inclusion, so I think we will have also soon the result of those first trials. It will be very interesting. Let's change now to the immunomodulatory approach, what is in this field. So not a lot of things. However, there is a possibility maybe with low-dose naltrexone. Naltrexone is an antagonist of an opioid receptors. It exerts anti-inflammatory and immunomodulatory activities, and it's used in some conditions that overlap with PAX, for example, chronic pain, multiple sclerosis. So there is very little results, but there is, for example, a retrospective cohort of 59 patients who receive a median dose of 2 milligrams, so you know it's 10-fold less than the dose you use in drug users, and for a median duration of 143 days. And at the end of the treatment, 62.5% of the patients reported improvement of at least one symptoms. 5 had to discontinue because of adverse events. So there is also a placebo-controlled trial, at least one, that is underway on the 160 patients in British Columbia University. Alors, a trial that is it's not a trial, and it's just a very recent report of 3 cases, very striking, of patients who had severe long COVID symptoms and had a rapid remission after 1 infusion of monoclonal antibody. I'm sure you all have seen these things. The initial infection was with pre-Delta variant, and they received the first generation of monoclonal antibody. It was casirivimab and indevimab. The name is Renoprev. So it's 3 on a series. The authors say in their letters that there is a series. And we don't know the exact mechanism of action. Is it a neutralization of the virus? It is a displacement of autoantibodies. Is it an enhancement of some immune response? We don't know, but it's interesting. And there is also a placebo-controlled trial ongoing on this field. Last for this part, it is the approach pursued by Patterson with maravigorot and pravastatin. Okay, I know there is a lot of criticism against its approach, but it is published. Huh? So in cardiovascular disease, we know that activated platelet, monocyte, and endothelial cells interact to create a prothrombotic environment and vasculitis. And in long COVID, it has been shown that spike protein was inside some kind of monocytes, the CD16 plus monocytes, and those monocytes activated express CCR5 and CX3CR1 fractaling. So the hypothesis is that by using maraviroc, which is a CCR5 antagonist, and pravastatin, which is a CCR3CR1 antagonist, this could disrupt this adhesion between monocyte, endothelial, and platelet and lead to macrophage monocyte apoptosis. So they published a pilot study with 18 patients who received the combination for 12 weeks, and they observed a decrease in some vascular marker, especially VEGF, and CD40L, and also an improvement in some function. So I know that some patients, they go to Patterson, they pay a lot to have this approach. I discussed with the team. The team told me that it is not constantly efficient, and the effect is not permanent, and sometimes there is also reactivation of latent virus. So be aware that it is really only pilot things. So let's move now to the anticoagulant and tissue oxygenation approach. So we had this morning wonderful talk by Eteresia Pretorius, but she didn't show her results because they are only on preprint. So following what she explained us, the finding of fibrin, amyloid microclots, and platelet hyperactivation, she treated 91 South African patients with dual platelet therapy, clopidogrel and aspirin, and oral anticoagulant therapy. For 2 to 4 months, there was those who were very early in the symptoms, they received 2 months. Those who were late in the symptoms, they received 5 to 6 months. And at the end, you can see on the right, they observed a decrease in a lot of symptoms. So it's an open study. We know that also long COVID could improve slowly. So it's only the beginning, but it's interesting. And I had a look on the secondary effect, because of course, to receive triple anticoagulant therapy, it's quite dangerous. So there was 5 patients who reported serious bleeding. But I think it's quite a fascinating approach, going well in the context of the physiopathology, and it's worth doing a randomized trial to prove if it's efficient or not. Also in these fields to improve oxygenation, there is a trial that tested hyperbaric oxygen therapy on neurological function. So you know that HBTO is sometimes used for patients after acute stroke or neurological severe confusion to improve neurocognitive function. But in this trial, 73 patients with neurocognitive disorder received 40 sessions of HBTO at 100% oxygen on 2 atmospheres versus control who receive only normal oxygen therapy. So it lasts a few months. It's very heavy as approach. And 3 weeks after the last session, a modest but significant improvement was observed, first in brain perfusion, and secondly, on cognitive function. It's really modest. It's really modest, and the limit of this article is that there is no follow-up. So we don't know if it's a permanent effect. But it's interesting, and it asks me the question of giving sometimes oxygen for the patients who are really severe to improve oxygenation. So other approach, I will not detail 70 trial, and just to focus to finish on the vagus nerve stimulation, vagus nerve inflammation and parasympathetic dysfunction. We all know that it is important in long COVID and that it contributes to dysautonomia. So the aim of VNS is to increase parasympathetic pathway and restore the balance between vagal, who is low, and sympathetic pathway will remain high. So it's an approach that a patient can have at home by self-administration at home of an auricular sonde, je sais pas comment dire. Okay. And in animal study of inflammation, VNS was associated with a decrease of inflammation, with an increase of anti-inflammatory effect, and a decreased tissue injury and increased survival. So our colleague from Belgium, they were the first to use this approach. They published in 2020 a small study where 20 subjects were treated daily for 35 minutes for 10 days with this approach, and they showed that nearly all patients had an improvement in symptoms, but there was no modification of inflammatory marker. So I had a look on the web and found that there were 3 little studies in this field. The first with 12 patients who received VNS or control for 2 weeks, and then there was an open label for VNS for everybody. Another study with 14 patients that were treated for 6 weeks, and in this cohort, 8 over 14 had an improvement. And at the first Congress in Belgium on long COVID last month, Professor Verbranck showed his results on 175 long COVID patients and that were treated with VNS, and showed that there was an improvement in 69% of them, and mainly on patients who had dysautonomia. It was partial in 96, and there was no improvement in 26. So I think that is also a logical approach, except if our patients are very, very impaired with dysautonomia. Maybe if there is some action of the vagus nerve remaining, it can help. So there are still many challenges. We are only at the beginning. And the 3 main challenges for me are to elucidate the interrelation between all the potential mechanisms that we have discussed. The first question is, are the viral antigens that we found, do they reflect replicative virus or not? And what is the exact toxicity of spike? That is really the 2 questions that we discussed this year, and I think next year we will have the solution. The second really important thing is to find a biomarker for long COVID. So it will allow to make a diagnosis, to guide therapeutic research, and several biomarkers have been discussed: the cytokine, the spike protein level, the metabolomic profile. Maybe it could be interesting, but not are present. But no marker is present in all population. For I think that our population are too heterogeneous. So it's not a cluster at the beginning, but maybe it's an evolution profile. We must define very different populations, severe, not severe. Because if we pull all the patients in the same study, it's confusing. And the last challenge, of course, is to find etiological treatment. Probably it will not be only an antiviral treatment, but maybe a combination of antiviral and maybe anti-inflammatory drug capable to cut this vicious circle. And at the end, we are only at the beginning of this therapeutic research, but even if we are at the beginning, we cannot let the patient in such dramatic situation, and it's crucial to begin trials. We have done that for acute COVID, we have done that for HIV, and even if the trial will not lead to the direct success, even a failure is important to learn something, and we can build on that. And I wanted to cite the Recover initiative from US. The NIH have defined 5 main axes: dysautonomia, cognitive dysfunction, fatigue, exercise intolerance, sleep disorder, viral persistence, and in each field there is a team building not only physiopathological study but also clinical study. So I hope that in Europe we will be able to join and to do the same. Thank you very much.